All right, thank you very much. So as indicated, I'll be presenting on the advancing universal health coverage, assessing the efficiency of contracting not-for-profit faith-based healthcare providers in Malawi, with specific interest on CHAM facilities. So that's a brief outline. Yes. So briefly, over the past now close to 2 decades, the government of Malawi has contracted or partnered with CHAM facilities to provide a predetermined set of services included in the EHP without charging any user fees at the point of use. And this is done through service level agreements. And in turn, the contracted CHAM facilities are reimbursed for the services that have been rendered. And also, the government also pays salaries for the healthcare workers in CHAM facilities. So what really motivated us to undertake this assignment is the fact that there is a literature gap with regards to the efficiency of SLAs, as well as the value for money for the SLAs. So we believe that the findings from this analysis will help to optimize public health spending and also ensure sustainability of SLAs in Malawi. So here, in this analysis we have 2 broad questions. The first question relates to the service level agreements, the prices that are quoted under service level agreements. And then the second research question relates to the salary block grant that is given to the healthcare workers. Next. So on the first question, what I'll do now for each of the questions, I'll look at the question and then I'll present the methodology that was undertaken, the analysis that was undertaken, present the results, and also the key message from that particular question, and then I'll move on to the next question. So for the first research question relating to the salary grant, here we ask the question as to, is the salary grant for CHAM healthcare workers an efficient use of government resources? So for us to answer that question, our primary conjecture is if there are efficiency differentials between healthcare workers in CHAM facilities and in government facilities, particularly if we find that CHAM healthcare workers are more productive or efficient than their counterparts in government facilities, then would say investing in healthcare workers in CHAM facilities is an efficient use of government resources. So those are the data sources. We took the data from MOA staffing data as well as DHIS2. Next. So in this analysis, for the first question, we used a 2-stage approach. In the first stage, we computed what we call a proxy for efficiency across different workers. So for us to do that, in the first stage, we computed the expected number of services delivered per cadre. And that is given as a product of the current number of healthcare workers delivering a particular service and the total patient-facing time available to that particular healthcare worker, or that divided by the total number of minutes available to that particular healthcare worker. And that gives us expected number of services delivered by that particular cadre. And then we compute what we call healthy worker efficiency score, which is basically the actual number of services delivered by a particular cadre divided by the expected number of services delivered by that same cadre. And then having computed the healthy worker efficiency scores, we now aggregate across cadres, because different cadres would be working to provide the same service. So we get all that in order to find facility level efficiency score. Next. So in the next step, we use OLS regression to regress the efficiency score on particularly on the facility ownership, which is basically an indicator variable or a dummy variable, which has the value of 1 if it's a CHAM facility, or value of 0 if it's a government facility. And we are very aware that there are massive heterogeneities between CHAM facilities and government facilities. So we do control for different factors, including service volumes, because one may argue that we may not compare CHAM facilities and government facilities because, say, the service volume in government facilities are relatively higher than in CHAM facilities. So we do control for that, and also the total number of staff, as well as urbanicity, whether the facility is located in rural or urban setting, as well as facility type. Next. Okay, so here are our regression results. I'd like to call your particular attention to the to this, for instance, different services. So here we only provide the result, the coefficient estimates for the dummy variable, which was indicated by CHAM. So that's what we provide there in the second column. And for most of the services that are statistically significant, and also if it's above 1, that means healthcare workers in CHAM facilities are more efficient in providing those particular services relative to their counterparts in government facilities. I think here we need to be very judicious in interpreting the results because, for instance, take inpatient days. So we find that the coefficient there is 1.61, which means healthcare workers in CHAM facilities are 1.061 times more efficient than their counterparts in government facilities in delivering inpatient day services, and that is only if we have the equal number of staff in CHAM, as well as in, we are comparing the same number of staff both in CHAM and government facility, and also if the service volume is the same, and also if the location, they are comparable. We are comparing a CHAM facility in rural against a government facility in a rural setting. So that's the interpretation of the results. This, I have to emphasize, does not imply that healthcare workers in general are more productive or are more efficient than CHAM, in CHAM facilities are more productive than in government facilities. So this, we are comparing based on the variables that we have controlled for. Okay, next. Right, yeah, so the same. For instance, also given, for instance, let's take HIV established medical complex treatment. So we see that for CHAM healthcare workers, they are about 48% more efficient than their counterparts in government facilities, or 1.48 times more efficient than their counterparts in government facilities. Right, next. So the key message from the first research question is that for most of the, for a certain number of services, CHAM healthcare workers are more efficient than their counterparts in government facilities. Now, the second research question, we look at the SLA reimbursement prices, because under the agreement, the government is supposed to reimburse 70% of the cost of delivering the services to CHAM. So we computed the SLA prices, which is basically 70% of the weighted price between private sector price and Central Medical Stores Trust prices. And having computed the SLA prices, we now compute the price ratios between SLA prices and the private sector price, as well as SLA prices and the Central Medical Stores prices. And then, next. And then we now aggregate all the commodities for which SLA prices are less than private sector prices, and that is given by the blue bars. And over the period, say from 2017 to 2021, we see that there is a 10% increase in terms of the commodities for which SLA prices are lower than Central Medical Stores prices. Okay, next. So from that, the key message is that the government is saving by contracting, the government is saving by contracting CHAM facilities, and the arrangement to provide the services by providing 70% or by paying 70% of the cost. And then the next question that we ask is, by how much is the government saving by contracting CHAM facilities instead of constructing their own facilities? So according to the MOU, the government or CHAM is prohibited to construct a facility where there's an existing facility that belongs to the other party. So, I mean, within 8 kilometers of the existing facility that belongs to the other party in the contract. So if the government now were to, say, construct their own facilities within the existing, within 8 kilometers of the existing CHAM facilities, they would incur about $871 million US. And just to put it into perspective, this would be equivalent to 5 times the national health budget. So the fact that the government is utilizing the existing CHAM facilities, so now the government is kind of saving this amount, which would be spent if they were to construct their own facilities. And in that case, that would be duplication of resources or efforts. Okay, next. So the two key messages from this is that from the first one, from the first research question, we find that given the same level of care and also the same number of staff, same service volume, and also urbanicity, healthcare workers in CHAM facilities are more efficient than their counterparts in government facilities for a good number of services. And also from the second research question, the key message is that the government is saving on both commodities as well as infrastructure by contracting CHAM facilities. And we advocate two policy recommendations. The first one is that the government has to renew the contract with CHAM for the SLAs as well as for the salary grant. And the second recommendation is that the upcoming CIP must emphasize the need to avoid constructing CHAM government facilities within the existing CHAM facilities as per the prescription in the MOU. Thank you very much.